Good evening. This is Susie Durie, and it's my pleasure to welcome you to the IMF's Best of ASCO, EHA, and IMWG webinar. Our speaker tonight is Dr. Brian Durie, Chairman of the Board of the IMF. ASCO, which is the American Society of Clinical Oncology, is another important meeting that takes place each year. The big difference between this meeting and ASH is that ASCO covers all types of oncologic diseases, whereas ASH focuses on hematologic malignancies. It's wonderful that so many people are listening in tonight to our call, as Dr. Durie will be presenting a recap on the most important developments and sessions that were presented at the recent ASCO meeting. And I'm sure you'll find this information to be very informative. Now, before I turn it over to Dr. Durie and he'll begin his presentation, I'd like to take a moment to thank our sponsors of tonight's teleconference: Amgen, Celgene, Janssen, and Takeda Oncology. It's really wonderful that they continue to support this program, and it's greatly appreciated.
Well, thank you so much, Robin and Susie, for these helpful introductions. I'm pleased tonight to be able to give this update, where, as Susie mentioned, I will focus on presentations coming from ASCO, but also from presentations that occurred in Europe, in Madrid in June, at the European Hematology Association meeting, as well as the presentations that occurred at the International Myeloma Working Group Summit, also held in Madrid. So if we can go to the first slide here. There we go, I'm so sorry. So the first slide, the topics for today's webinar, I've decided to focus on 5 different topics, which I think encompass some of the main discussion topics that have emerged from these presentations that occurred in this middle part of the year. And so I'm going to focus on imaging for 2017, what kind of x-rays and scans are now preferred, what will be the impact of some of these new agents that we see moving forward in trials. Will they start to impact frontline therapy soon? What is the impact in decision-making related to minimal residual disease testing, MRD testing? And then of all of the new therapies that are being presented in the relapse setting, which ones really do look like they are the most promising and will move forward into additional testing and possibly even ultimately into that frontline setting? And a big topic that is increasingly being discussed is what is the impact of the cost of therapies and the total cost of myeloma care. So if we move first to what is the ideal imaging in 2017, I'd like to start this by focusing on what is the overall baseline testing that we recommend in 2017. And a key aspect of that in thinking about, does a patient have MGUS, smoldering myeloma, early active myeloma, or active myeloma, is that imaging is a key part to that. Once you have measured the spike, the free light, the bone marrow testing, once you've done these different things, the key discriminator often tends to be what is the result of the imaging or scans. And so, for example, for the MDE category that you see on this slide, myeloma defining events. First of all, for early active myeloma, this can be determined if the bone marrow shows up 60% plasma cells or more. If the free light ratio is 100 or more, the kidney function is slightly deteriorated with a clearance of less than 40, or, very importantly, and often a key aspect, does the MRI show 2 or more focal lesions, so abnormal spots on the MRI scan. And this is sufficient to say that there is a myeloma defining event and early active disease. And so this is different than the CRAB criteria, where we're looking for lesions possibly on X-ray or some other kind of scanning. But if we go to the next slide, we can see that there are a lot of options these days. And the traditional skeletal survey, which many of you may have had with regular X-rays, is now being very much replaced by either whole body low-dose CT scanning, a PET CT scan, or MRI of some sort. And as I'll show you in a second, results were presented at the EHA meeting and are now going to be coming out in publication. It's clear that whole body low-dose CT is significantly better than just doing traditional X-rays and is the best for early screening. For ongoing monitoring, PET CT and MRI are also part of the important diagnostic equation. And I'm going to discuss what are the pros and cons of PET CT, MRI, and also a new variation on MRI, which is called DWI MRI. And things are changing quite rapidly where that may be an option, or also something completely new where PET scanning could be directed by the results of a gene expression profiling result, GEP-directed PET CT scanning. So lots of new innovations that are moving forward here. If we go to the next slide, you'll see the study that was presented at the EHA meeting and is now going to be coming out in publication in the journal Leukemia soon. This is from the German team led by Dr. Jens Hillengass. And what you can see here, and I've highlighted now in the extra red boxes, was that there were 23.9% patients who had negative X-rays. They had the whole skeletal survey done, and nothing showed up. There were no lesions showing on the X-rays. However, on the CT scan, they had obvious lesions. And so 23.9% of patients had lesions on CT, but negative X-rays. And this is a huge difference at the time of early diagnosis, because this tells you if a patient has myeloma or not myeloma. And so, as I mentioned in the smoldering myeloma trial, this has meant in the screening for smoldering myeloma that many patients actually turned out to have myeloma rather than smoldering myeloma. Now, if we look at the additional imaging techniques, CT scanning shows what is occurring in terms of bone damage. MRI shows the circulation or the amount of cellularity related to myeloma in the bone marrow. And it shows up with different pictures that you can see across the bottom of your screen. And so you can see 2A, for example, just shows kind of a dark area where the MRI is abnormal. If you go all the way over to the right, where you have a method which shows the microcirculation and the cellularity, you can see a lot more detail with these specialized MRI testing methods. Now, this also compares with PET scanning, where the uptake of sugar also gives you a much more precise picture of what's going on within the bone. This is an important aspect which shows that with the new MRI technique, with the DWI, diffusion weighted imaging, it is impacted by the age of the patient, and so the amount of uptake actually goes down a little bit with age, and so we need to be aware of that when we're looking at the comparison between a normal and an abnormal diffusion weighted image. And so, in summary, what do we do in terms of imaging right now? And there was a new paper just published in Blood this past week from the Italian group in Bologna with Elena Zamagni as the first author, who outlined what the future looks like for imaging in myeloma. And the options are that if in this trial setting, both the MRI and the PET CT scanning are done, what we know already is that there are three possibilities. For the majority of the time in the preliminary testing, 82% of the patients will have a positive result with a PET scan or the MRI. So this is great. Now, 7% of the time, both will be negative. The important aspect of that is that this is mostly in patients who have very, very early disease. They have less than 20% plasma cells, and they would tend to have normal FISH test results. The important group is over on the right, and this is 11% of the patients, and these are patients where the MRI test is positive, but the PET CT scan is negative. This is 11% of the patients, and this new study published in Blood showed that this is because the myeloma cells in this case don't handle the sugar in a normal way. The sugar goes into the myeloma cells but is not retained because of low expression of a sugar-related gene, HK2, on the GEP testing. And so because of this, there is a negative PET scan. But the correlated piece of information is that this is mostly in patients who have an obvious high level of bone marrow plasma cells. So this means that even although the PET scan is negative, it's obvious that it's a false negative because the bone marrow is filled up with myeloma, and so it's obviously a false negative. But this is something that is going to be an aspect of how scanning will be evaluated moving forward. And the results of this ongoing prospective study will be available in the future. So a lot of new information about scanning, and I know that there may be questions about the availability of those types of scans, and also costs and reimbursement, which often drives the use of different scans in different centers and different parts of the country. So the next topic, how will new agents impact frontline therapy? This is slide number 10. The frontline therapy, which is the standard of care, and this was a topic that was presented actually by myself at the IMWG summit in Madrid. The current standard of care has become the Velcade, Revlimid, and Dex regimen as compared to Revlimid and Dex, the two-drug regimen. And this is based on the results of the 777 SWOG trial, in which the three-drug regimen was compared with the two drugs of the lenalidomide and Dex. And in this particular trial, the results showed an obvious benefit in terms of the remission, which is the progression-free survival of the VRD, the three-drug combo versus the two-drug combo, with a remission length of 43 months versus 30 months. And then if you go to the slide 13, the overall survival was also impressively improved at 75 months versus 64 months. So over a year difference, well, sorry, 11 months difference there. So just the fact that an average survival coming out of a trial is in excess of 6 years is definitely a landmark. And even in the poorer arm, the average outcome for Revlimid and Dex is over 5 years. And I would also point out that although VRD is better than RD overall, you can see that plenty of patients are doing just fine with the RD doublet. And one of the next projects is actually to identify which patients can do beautifully with just the RD as part of their therapy. The key part of the VRD benefit is that more patients had deeper response. And so in slide number 14, the progression-free survival with a 6-month status, the green line shows that the patients who had at least a 90% response, a VGPR or better, were the ones that had the very, very best survival, with a median progression-free survival of 49 months, actually, which is really pretty impressive. And so, based on these results, the current standard of care in slide 15, the mSMART recommendations are that for the different types of risks of myeloma, the 1114, 614, the standard risk, or the trisomies, VRD, intermediate risk, the 414 VRD, and really the only group where we might look at a more intense regimen is with the KRD for the high-risk group. And then for the transplant ineligible patients, basically across the board, VRD would really be the recommended approach. But what emerges rather quickly is what is the availability of these novel combinations? And this map here is quite sobering as far as KRD and availability in the frontline setting. Outside of clinical trials, if you have a high-risk patient, this would only be an option here in the US and in Germany and possibly in Japan. If you look at the availability of VRD, which is the standard of care, where is that available? Well, actually, that is only available in the US, the Nordic countries, Germany, and Japan and Taiwan, I believe. So very, very limited availability. And then if you look at the availability of the VCD, then this is not something that we're saying is the recommended standard of care, but that is what is widely available all around the world. And so that actually is what patients tend to get outside of the US. And so at the IMWG summit in Madrid, Dr. Sagarlonio from Emory presented the fact that in a recent COMPASS study, VRD in a head-to-head comparison was clearly superior to the VCD, which is the CyBOR-D protocol. And so, excuse me, so this is certainly something which is quite sobering, where we know that something which is not ideal is something which is the most widely available, and something that we need to think about carefully for the future. Are there any new combinations which look more promising? Well, at ASCO, there were 4 presentations of new combos in the frontline setting. Durvalumab plus Revlimid Dex from Sagarlonio again. This is a checkpoint inhibitor. Actually, this particular study has been closed because of concerns about increased toxicities with the checkpoint inhibitor combinations. Elotuzumab VRD was also presented, but actually this study also had some concerns because there was an increased occurrence of significant infections using that 4-drug combination. What was clearly beneficial was the KRD versus KCD from the Italian group, and so it's pretty clear that if you have a proteasome inhibitor and an IMiD combination, it's better than the other kinds of combinations. And what was very helpful was to see that daratumumab can safely be given along with the KRD as presented by Dr. Jakubowiak from the Chicago group. And so what does the future of frontline therapy look like? Well, right now, VRD is the standard of care. It might be switched out so that maybe Dara-RD could be an option. Very, very effective 3-drug combination using the daratumumab anti-CD38 antibody. Or likewise, you could switch out the Revlimid and use the Dara-VD combination. And both of those have excellent results, the Castor and Pollux results in the first relapse setting. But moving forward, what most people are predicting will become the standard of care is, if not VRD, try to use VTD so that you do have an IMiD proteasome inhibitor combination. But ideally, the best results are most likely to be with KRD plus Dara if feasible. Moving forward, the checkpoint inhibitors are a little bit questionable now. I shouldn't put a complete cross through them because we don't know that yet, but the 3 Merck studies were closed by the FDA this past month because of unexpected toxicities combining the checkpoint inhibitors with either Revlimid or pomalidomide. Bispecific monoclonal antibodies may turn out to be really useful. CAR T cells, I think it's too soon for us to know. However, in the news today and in the Myeloma Minute, I discussed the approval by the ODAC committee of CAR T cells for the treatment of B-cell leukemia in children and early adults. So it looks like CAR T cells are going to move forward, and we'll see if they turn out to be useful for myeloma. Okay, so a next very important topic that came up in many presentations and discussions are what is the value of MRD testing at the present time in trials or even outside of trials? And so if we go from slide 23 to slide 24, clearly measuring MRD, you are measuring the depth of the response going all the way down, and you can use flow testing or molecular testing to get all the way down below CR, stringent CR, to molecular or flow MRD negativity, down to the very bottom of the iceberg of myeloma, so that you can see that there's nothing left at the bottom. But the question is, if you do have that information, what are you going to do about it? And so here on slide number 25, I give you 2 possibilities just to discuss for a moment. So let's say you have gone through successful therapy with BRD, you maybe had a transplant, and you've been on maintenance for a year, and you're MRD negative. What are we going to do? Do we recommend that you stop your therapy? And this is the natural intuition. But as I discussed with Mary V. Mateos in our conference series, which some of you may have heard coming from Madrid, she said, Dr. Durie, you have to be aware that those patients who get to be MRD negative are actually the good risk patients who are benefiting from ongoing maintenance. And so the best strategy might be to keep them on maintenance, even though they're MRD negative, to get that ongoing benefit. And then if they're MRD positive, what should we do? Well, what she pointed out is something that we need to check more carefully, is that if the myeloma is remaining, we need to understand better what is the nature of that myeloma that is left. Is it maybe just an MGUS? And maybe it's safe to stop. So maybe the actual correct answer is that you continue with the MRD negative, and if the MRD positive is an MGUS, maybe you could stop treatment. But obviously, some of the MRD positive is serious myeloma where you will definitely need to change the therapy. And so what we need to focus on is testing, which can be achieved with the next generation flow testing, actually, is to figure out the nature of the MRD positive. But the recommendation is not quite what you might think about intuitively. So at the time of the meeting in Madrid, Dr. Mary V. Mateos did present initial results from her CAESAR trial, which is the curative strategy for high-risk smoldering myeloma. And you may have heard about this trial. This is a trial, if we go to the next slide, which summarizes the protocol for the CAESAR trial. This is a trial which involves 90 patients with high-risk smoldering myeloma. And so those are patients who have early disease but do not have those myeloma-defining events. And so they do not have those bone lesions that I was focused on at the beginning of the talk. And so a very, very key aspect is, do these patients have bone lesions? If they do, well, they actually have myeloma. Well, these are patients who have a slightly earlier disease using Mayo Clinic and Spanish criteria, and they have received 6 cycles of Kyprolis, Revlimid, and Dex, a transplant using high-dose Melphalan, further KRD, and then Revlimid, Dex maintenance for 2 years with MRD testing along the way. Well, the good news is that Mary B has fully accrued this trial. So all of the patients have gone through this, certainly the first part of this therapy. They're accrued into the trial and are being studied to see if they are achieving an MRD negative status, if they're having a dramatic response to this therapy, since they're being treated at a very early stage. So if we go to the next slide, recruitment was completed as of June, so this just happened. It was a very interesting point that during the screening, PET-CT and whole body low dose CT was used for the screening, and 36 patients that were thought to be smoldering was what are called screening failures. They actually turned out to have myeloma, so they were not eligible for this particular trial. In the trial so far, 42 patients have completed the first part, 34 are already through the transplant, and 22 heading now towards maintenance. There's really only been one serious problem. There was one older lady who had an infection and actually died with a stroke, which may or may not have been in any way related to the treatment. And so, excuse me, if we just go back for a second, the results are promising. The results will be prepared for submission to ASH, and so you should be expecting to have an excellent report from this trial at the time of ASH. I can tell you that 100% of patients have at least responded with something better than a partial response, and of those, many are moving towards complete remission and an MRD negative status. But we'll get the full report, as I say, at ASH in the first week of December. There is another trial which is just starting, which is the ASCENT trial, and we got an update from Shaji Kumar in Madrid. This is all finally agreed and approved by the appropriate pharma companies. This will be KRD plus DARA, a 4-drug combination with an option for transplant with further KRD and then maintenance for 1 year. And so this will be important to see what is the benefit of adding daratumumab in terms of the achievement of MRD and sustaining the MRD out to 1, 3, and 5 years, which is the goal of both of these trials. So very interesting days to see the benefit of this early active therapy. So the next question is, where are we with all of the different new drugs? We were very fortunate in 2015, if you look towards the right of slide number 30, that we had 4 new drugs approved in 2015. Daratumumab, the anti-CD38 antibody, Activism, the proteasome inhibitor, which is by mouth, elotuzumab, another monoclonal antibody, and panovinostat. This really was a huge thing, but the question is now, number one, what has been the impact of those new drugs in the big picture, and what are the new ones that are coming along to add to this menu. So at ASCO, what was presented at ASCO? Well, there were a number of presentations related to relapse therapy using new combinations. The results of the CASTOR and POLLUX trials were updated. CASTOR is daratumumab Velcade dex versus the Velcade dex alone. This was presented by Dr. Lynch, and she showed obviously that the Dara Velcade dex was doing a fantastic job, and in fact 10% of the patients getting Dara VD were MRD negative at the 10 to the -5 level, and this is in the first relapse setting, so this is quite remarkable. MRD negative even for a relapse patient. More impressive was the POLLUX study, Dara Rev Dex, in which 25% of the patients in this first relapse setting achieved MRD negative, so quite impressive. As far as new therapies, there is another monoclonal antibody against CD38. It's called isatuximab. I'm glad I have it written there so I can read it. combined with Pomdex, good results with that. And then there's a randomized study with Dr. Paul Richardson as the PI, where we'll see what is the benefit of this other anti-CD38 antibody. Several studies were presented using the checkpoint inhibitors, of which there are Atezo, Durvalumab, and Nivolumab. There is concern now about those combinations because of some increased toxicities that have been observed, and actually 3 trials were shut down because of that. Another interesting study which was presented at ASH, and now there are several groups looking to start new trials with this, is Nelfinavir. This is the AIDS drug, the HIV drug, which can overcome the resistance to bortezomib dexamethasone. And this is a trial coming out of Switzerland. Very, very interesting study. Patients who had progressed and were failing on bortezomib dex, Velcade dex. And if you go to the next slide, the best response, you can see there were some pretty dramatic responses for around 70% of the patients, with a number receiving VGPRs or solid PRs, and only a few patients, 3 patients, having strong progression despite this therapy. So this is very interesting because this is a commercially available drug which is relatively cheap, and so several people are interested to show that this is beneficial in other trials and move forward and try to make this available for patients. So the next slide summarizes where are we with immunotherapy, and I have a slide here which shows all of the activity in this area of immunotherapy. And so a lot of presentations related to lab work, early clinical studies, and other trials related to all these different immunotherapy agents. And so this is where people say, well, this is where most of the action is occurring right now. The different antibodies, the vaccines, even the cellular therapies, but I put a red box around the CAR T cells. And so these are the chimeric antigen receptor T cells. So this is what's called cellular therapy, and this is a type of therapy where the T cells are taken from the patient, genetically engineered, and then are given back with a particular target to try to kill cells. In this case, the most promising in myeloma is against BCMA, B cell maturation antigen. And you can see there's so much interest in this that actually 8 different companies, the NCI, the Bluebirds, even a Chinese group, are doing studies with this. And in fact, the Chinese team presented their results at ASCO and created quite a stir, because they said that their results were so good that they think that they were going to be able to cure myeloma. And I think that people were saying that this could be maybe slightly premature and that the results were good, but, you know, was there MRD negative? Not sure. Was there MRD negative sustained? Way too soon to know that. And also, in some of these trials, there's quite a bit of toxicity that needs to be evaluated much, much more closely. In some cases, some very dangerous toxicities. But so some of you may have noticed that I did write a blog about this, which is focused on the hope, of which there is a considerable amount, but also to be cautious about overly hyping all of these results before we know the true impact and certainly the longer-term outcomes for these patients. Overall, even although 8 different companies are working on this, less than 100 patients in total have been treated so far. So very, very early days, although very, very exciting. So how good are all of these novel therapies? Well, I think the CAR T cells, certainly dramatic, deep responses. Toxicities, including a cytokine storm, where there can be dramatic inflammation of the brain, actually, which is very dangerous, and then ongoing immune deficiency, which can create susceptibility to virus and fungal infections, something that needs to be still seriously considered. But the deep responses could be very powerful, and certainly in the relapse setting, an important option to have available. The checkpoint inhibitors, I think the immune toxicities, which has led to the closing of 3 trials in the last month or so, I think we just need to wait and see what will be the future for those. Among the other agents, we have good results with selinexor, which is in phase 2 trials right now. Phase 3, actually, there's a randomized trial. This is a new target that leads to the accumulation of anti-oncogenes in the cell. Promising results with something called the STORM trial, which is a relapse trial in which patients receive selinexor plus dexamethasone. The Nelfinavir I mentioned. In the works and coming forward, we know about thalidomide, Revlimid, and pomalidomide, but there is a new IMiD beyond POM which is moving forward into trials, and people are interested to know, well, how much more mileage can we get out of IMiDs? Because we already are doing a pretty good job with the IMiDs that we have, but there is a new one moving forward. And finally, how important is cost? Well, it's pretty clear that cost is becoming a huge, huge issue. I just put it on my next slide here to put in perspective. If we click to the increasing depth of response in myeloma, which could also correlate to the increasing cost of myeloma, you have depth and cost that are moving in parallel. And this is just to give you an idea. The double therapy regimens, RD, about 100,000 per year. Also, Cytoxan, bortezomib, and Dex, where you just have one novel agent, around 100,000 per year. If you have 2 novel agents, VRD or KRD, $250,000 a year, just huge, huge costs, and hard to understand how the financial system, the personal budgets of everyone could possibly handle or sustain these sorts of costs over time. And as you saw, the future of frontline therapy is looking like VRD or KRD plus DARA. So one more drug, one more, I don't know, $100,000 to add to that for your tab for the year. So it really is a very difficult area. And so, you know, how much does cost truly impact access, choices, and outcomes? I think the answer to this is really becoming yes. It's important for all patients. All patients are having their choices impacted by cost. And at the IMWG summit, the main little bit of good news that I would give you is that this was a very, very emotional topic among the doctors at the IMWG summit in Madrid, who were clearly very focused on what can be done to address the overall costs of myeloma care and in terms of the costs of the specific myeloma drugs. This is a complicated problem. In the US, it's impacted by, for example, the inability to negotiate on the costs of drugs for Medicare, for example, and there is not a value-based costing or pricing system that is operational in the US. I would say that there is such a system that does come into play in Europe and does impact the approval of drugs outside of the US. And so a lot of different options and possibilities, but clearly the IMF is committed to do our best to help patients to understand their options and getting reimbursement, and even trying to select an option which may be reimbursed within their healthcare program that may be equally or similarly effective in their particular situation. But I'm happy to take questions on this topic. And so these are the main things that I wanted to cover tonight and leave time for questions. So hopefully this has been helpful and interesting, and I'm glad to take questions that have popped into your mind during this presentation. This last slide shows our sponsors that we really, really appreciate their support and supporting the value of these kinds of informational presentations. And so from the IMF, I'll say thank you, appreciate the chance to convey this information, and we're open for questions. Thank you.
Okay, Dr. Durie, that was really informative, and we have lots of questions coming in. So as a reminder for everyone, please remember to type your question in the control panel under questions, and we ask you that these questions are general in nature and specific to myeloma to benefit all listeners on this webinar. So Dr. Durie, our first question tonight comes from Jack, and he asks, for Maria V's CSAR trial for the high-risk smoldering patients, is it possible that a patient could be MRD negative at the outset?
No. This is, I'm assuming, Jack Aiello, so thanks for your question, Jack. Yeah, so patients coming in, they do have myeloma in the bone marrow and in the blood, actually. And so they do, in smoldering myeloma, you do start off MRD positive, okay? So definitely MRD positive. The level of myeloma is obviously lower, but yeah, so the measurable disease, and then with becoming MRD negative as the key goal of the treatment.
Okay, so now we have a question from Tony, and Tony is asking, is MRD testing available outside of clinical trials?
Okay, good question, Tony, and this has been a goal for the IMF to assess how this might be feasible. And so MRD testing can be requested by your doctor in two ways. For the sequencing method, NGS, there is an available testing through the Adaptiva company, and so this can be sent off to the commercial lab there. And so there can be a concern about reimbursement for that, which can be in the range of $1,000 or more for that. There is a new option, which is the next generation flow method, and the good news there is that the Mayo Clinic has just achieved a CLIA approval status, which means that they're approved to accept samples that are sent in by your doctor to the Mayo Clinic. That's the Mayo Medical Labs, which many of you may be familiar. That's actually where a lot of myeloma testing goes anyway for testing. And so this Mayo Medical Lab CLIA approved NGF MRD testing is coming online at the end of this month approximately. And so check for that, but that will be a cost-effective option. That does cost more like a couple of $100, and it seems like in the way that it's set up for the antibody testing, it would be reimbursable, but important to check that ahead of time. So both tests are available in the US, okay?
Okay, thanks, Dr. Durie. Our next question is from Ronald, and he asks, how long do you estimate it will be before immunotherapies will become mainstream treatments?
Okay, another very good question. So it's important to note that daratumumab is an immune therapy. I mean, it's a little bit different in that daratumumab anti-CD38, a monoclonal antibody that attacks cells with CD38 on the surface, it does attack the myeloma directly, and also kind of tunes up the microenvironment. But it is an immunotherapy which is very effective, and it's obviously approved as a single agent and in combination with Revlimid and Velcade, and also very recently got approval in combination with pomalidomide. And so we do have an approved immunotherapy, so to speak, in the form of daratumumab. Elotuzumab is also an immunotherapy. And so that has also received FDA approval and is commercially available. So we do have that, but the question is really about these newer ones. I think it will be a little bit of time before CAR T cells, for example, will get to be approved in myeloma. The lead method there is the CAR T BCMA strategy, which I would estimate could be at least a year or two away. The other antibodies, the bispecific antibodies, the checkpoint inhibitors, I would say are at least a year or two or three away. But the key question will come, and I tried to point to this in thinking about frontline therapy, is obviously a lot of these therapies will be really, really good and important salvage therapy for patients who've relapsed, but will they really add to what we're currently achieving in the frontline setting? And that is a question that is very much open still, if they're good enough to really give deep responses that will add to what we can currently achieve. And so it'll take time to know the answer to that, and also to know if these combinations with IMiDs, for example, are really safe for myeloma patients.
Okay, we have a little bit of a follow-up question on CAR T from Dimitri. And he asks, regarding the cytokine storm side effects with CAR T treatment, is there an effective prevention or treatment strategy for this?
Well, yes, there are great cautions related to that now. There's an awareness about the possibility. The first thing to say is that the CAR T storm seems to be quite variable between the 8 different products. So the eight different companies are looking at that for BCMA and myeloma. And so, for example, the Chinese study, they didn't report as much of this cytokine storm, where a couple of the other companies have actually had to temporarily close down their trials because of the cytokine storms. But the other point is that because of this, this treatment is being focused at certain institutions. So, for example, the CAR T that is just headed for approval in leukemia, there would be 30 centers where people would be educated to really take the precautions necessary to be on top of the cytokine storm situation and to treat aggressively and immediately if there's a brain swelling situation or any other types of problems that emerge. But this is not trivial, and something which is a little bit of a concern is that the occurrence of the cytokine storm, it does indicate that the treatment is really working powerfully, and so it does mean the treatment is working. And so in a sense, you don't want to get rid of the cytokine storm because then you get rid of the benefit. And so it's going to be a fine line between having maybe some cytokine storm and retaining a good maximum benefit. But really, the CAR T cell therapy is not trivial and should really be given at specialized centers where they have experience in this.
Okay, now we have a question from Ginny, and she's wondering about, you didn't give any mention on a trial of DARA plus Cyborg-D, and is there any updated information available? Not so much in terms of efficacy, but that's definitely a tolerable and active regimen, and so I think that we will see more results on that. I think that it does highlight a point, which is, when we're looking at all the different combinations and trials, which ones should we prioritize? So, for example, I showed the slide from the Dr. Sagaroniel from the COMPASS study, where he showed that VRD was better than Cyborg-D, VCD. And so if we know that VRD is better than VCD, then there would be a priority for us to study, DARA
plus VRD, because then that you would expect that to be better. But then, you know, maybe for someone who can't use Revlimid or thalidomide, we need to know about the VCD combos. And so it does get to be tricky and very expensive to think about all these different trial combinations and which ones are the most important to do a large study. But I would tell you that certainly the Amgen company and the Janssen company are very much focused on moving forward towards KRD or KRD plus DARA as what would be considered the kind of top of the line. And the VCD type of combos are going to be tested in smaller studies. And I'm sure the DARA does add, but it's not been a priority as a larger trial.
Okay. We have a question from Joyce about testing, and she says that her oncologist tends to only use an X-ray for testing, and she's curious about what the benefits are for more advanced testing such as the PET-CT, and some institutions are using the PET-MRI more recently. Can you comment on that?
Right. So I think that this has reached a point where I was going over all the different imaging methods, and it's clear that there are a lot of innovations and new data, and I think that there's a big educational challenge right now where we definitely need to update at that local doctor level and even at the specialized centers level that regular x-rays, I mean, if you see a lesion on a regular x-ray, that's fine. But if the regular x-rays are negative, as I showed you, there could be 23.9%, 24% of patients could still have lesions. And so there's a high level of caution. And at the patient level, if there's really any question, additional imaging has to be done, either CT or PET-CT or MRI. And this very much depends on what sort of equipment and reimbursement are available. Sometimes a company will reimburse MRI, they might not reimburse PET-CT, but definitely some additional imaging is important, essential, if you want to rule out new disease. If there's a question, is the myeloma relapsing? Well, you don't know the answer to that unless you've done like an MRI or a PET-CT scan to see if there is new active disease on the PET, for example, taking up sugar and showing an area of active myeloma. So it's important for patients to push for that. But on our side, it's very important for us to be doing a better job to educate at our professional meetings, doctors across the board, to be up to speed with all of these new results.
Okay, we have a question from Adrian, who is interested in the updates on the selinexor trial, and were any combinations presented?
Not recently. Obviously there are several trials going on. The selinexor dex is active in the unmet need relapse setting, but very, very positive results with selinexor Velcade dex, and there's a big trial, the Boston trial actually, that's going on with that and is accruing patients. And then there's also another study which is selinexor carfilzomib dex, and so Dr. Jakubowiak has presented a couple of times the promising results with carfilzomib selinexor dex. The strange thing is that actually these combinations seem to have lesser toxicity. Giving the extra drug actually seems to reduce the toxicity, which is kind of a strange thing, but I think there's going to be quite a lot of interest, especially in the follow-on to Dr. Jakubowiak's very positive carfilzomib data. Okay, so but there was nothing really much new, but besides the fact that it's a pretty active combo, so something to be thinking about.
Okay, I think this may be our last question of the evening, and of course Susie is going to let everyone know about the info line for additional questions. So Dr. Durie, the last question for tonight is now, what is the role of autologous transplant in the current era of novel agents?
Well, the decisive answer that came out of the IMWG summit, so we spent this was a whole session at our summit where we talked about this, and the bottom line is that all of the experts unanimously recommend that we should be still considering a single autologous stem cell transplant with high-dose melphalan as part of the preferred care for patients with myeloma. Now, this would be for patients who are, eligible, able to tolerate it, etc., not the older patient where, it may not be feasible. But we are still faced with the data from the IFM 2009 trial, where a randomized study where half the patients had the frontline trial with the stem cell transplant and half of them did not. And in this trial, obviously the initial remissions were longer in the patients who got the frontline transplant, but thus far the survival is equal. And so one way of looking at this is certainly for the first 3-4 years, patients can do equally well without pushing ahead with the frontline transplant if they have the stem cells harvested and would be able to do the transplant later. We need to wait for the longer term follow-up. Most people are suspecting, because more MRD negative is occurring with the transplant, that patients getting the transplant will definitely have a better survival ultimately. But the flip side is that if patients don't want to do a transplant or can't do a transplant, it seems like it's not the end of the world, that if they could harvest their stem cells, there's obviously a strong option to save those stem cells and be in a position to consider doing it later. So it is still a primary recommendation across the board if feasible, but if not, still very reasonable to look at using it and doing it later. All right, well, thank you all. These are great questions, and appreciate that.
So this is Susie. Thanks, everybody, and I hope that you really enjoyed listening to Dr. Durie give you what I think is a great update. Of course, I'm a bit prejudiced on that. I know a lot of you didn't have a chance to get your question answered, so I suggest that you contact our info line, and they'll definitely be able to help you. That number is 800-452-2873. And another fantastic way to stay abreast of all the new data and how it impacts your treatment options is to attend one of our patient seminars. Our next seminar will take place here in Los Angeles on August 18th and 19th. And to register, you can call us at 800-452-2873, and you'll be glad you did. It's our last seminar of the year. Our last patient seminar of the year. We have one more after that. Will be held in Dallas, Texas, October 6th and 7th. My colleague, Kelly Cox, who many of you may know, will be holding regional community workshops across the country. And to find out where they're going to be held, again, call our toll-free number, 800-452-2873. I can't thank our sponsors enough, so I'm going to do it once more. I'd like to give a heartfelt thank you to Amgen, Celgene, Janssen, and Takeda Oncology. And that's it. Thanks very much, and everybody have a lovely evening.
Okay, so thanks to everyone.